Okay, we're going to quickly go through the postpartum complications. Right. Okay, I had to lift that up a little so you could see the whole slide. So, postpartum hemorrhage is defined as any amount of bleeding that places the mother in hemodynamic jeopardy. So, if she loses more than 500 milliliters in a vaginal birth or 1,000 milliliters in a cesarean birth, then we put her in a postpartum hemorrhage protocol, meaning we're going to do extra steps to protect her, make sure that she is not going to have risk of bleeding and having hemorrhagic shock or hypovolemic shock. So it can occur in two different ways. If it occurs within 24 hours after delivery or birth, then we call this primary. If it occurs anywhere from 24 hours to 12 weeks after birth, it is called delayed postpartum hemorrhage. So we're going to define postpartum hemorrhage and the causes with four different, we call them the 4 T's of postpartum hemorrhage. They are tone, tissue, trauma, and thrombin. And we'll go over them a little more in depth. So for tone, we're talking about the tone of the uterus. An atonic uterus is going to keep bleeding. We want that uterus to be constricted. I think I've just belabored this. You know exactly what I'm talking about. There are many causes for the atonic uterus. And this is the number one cause of postpartum hemorrhage. And it can lead to hypovolemic shock pretty quickly. So we'll do things like, I will show you in the next PowerPoint presentation what we do for uterine atony. So we're looking for the clinical manifestations of hypovolemic shock, right? Diaphoresis, cool extremity, maternal anxiety, then tachycardia, hypotension, oliguria, and then agitation, confusion, and then she has that hemodynamic instability. And this comes right from your ATI. All of these do. So the next T is tissue. And we're talking about retained placental fragments, clots that are really big. If she has really big clots in her uterus, it will occupy space where the uterus cannot constrict down. Placenta accreta, where the placenta adheres too deeply, remember, into the uterus. And then subinvolution, meaning the involution of the uterus is how it loses that endothelial layer and completely resurfaces, so a fresh new endothelial layer. If that is not returning, if it's staying large and it's not going down to its original size where it's just right there in the pelvis, then we know that it's not contracting. So uterine fibroids are also a reason for uterine atony. So if you see these fibroids, which many women get, they're non-cancerous tumors, and they grow along this uterine wall, they can stop the uterus from constricting if they're rather large. So they want to know about these fibroids before, so they're aware that this will be a risk factor for postpartum hemorrhage. And then the next T is trauma. So any kind of hematoma, remember with that pudendal block, it can cause a hematoma. So we want to make sure we're looking at that kind of blood loss from the hematoma. Any kind of laceration from the birthing process, or uterine inversion. So this happens when if the provider actually takes the placenta out before it's ready and it's fully attached, still they can cause the uterus to actually invert. And here is a picture I have of the hematomas that can occur. So if this is kind of to orient you to the slide. So this is the vaginal tract, and this is a hematoma right here. This is that vulvar hematoma caused by the pudendal block that you can see. And then you can also see, if this is the vaginal opening right here, you can see it over here. You can have all sorts of hematoma. So that's why it's important to really look at a woman postpartum to see if she has any of these hematomas, and sometimes they're completely hidden. You can't tell just from looking at assessing a woman. These are those lacerations that can cause, if these aren't repaired sufficiently, then they can cause postpartum blood loss or hemorrhaging. And then this is the uterine inversion. So if they pull the placenta out and it's still attached to the uterus, they can actually pull the uterus out and they have to kind of prop it back in there. The last T is thrombin, and these are clotting disorders. And there are 3 different kinds that the ATI and your NCLEX will want you to know. The first is ITP, or idiopathic thrombocytopenia purpura. And this is an autoimmune disorder where there is this increase in platelet destruction. And it's, interestingly enough, most common in women of childbearing age. So they don't know if it's associated with maternal and fetal complications, and that's what it causes it, and it leads to the ITP, but it is an autoimmune disorder, and if a woman has ITP, they want to know that going in because she has a decrease in her platelet ability. So she will have decreased platelets going in and won't able to clot if she does have any sort of bleeding. Von Willebrand disease, the VWD, this is a congenital bleeding disorder, and most people know this if they have this going in, and your doctor will know this, or your healthcare provider will know this from that history that they took. And with a von Willebrand disease, they want to know this so that they can be aware of this. It causes an impairment of platelet adhesion, so there again, clotting disorders. And then the last one is DIC. You guys should be familiar with DIC from pathophysiology and your med-surg classes. This is the abnormally activated widespread clotting, and so they kind of blow through their platelets. And it can occur as a complication of many different things: abruptio placenta, so placental abruption, amniotic fluid embolism, any kind of intrauterine fetal death or miscarriage, and then preeclampsia and HELLP syndrome, any kind of sepsis, and postpartum hemorrhage. So we're going to treat DIC like you would in any other DIC circumstance, where we're going to treat the underlying cause and then let those platelets rebuild up so that they have a good amount of platelets. The other thing that we're going to look at, so that was postpartum hemorrhage. Now we're going to look at venous thromboembolism. That's the other thing that we're going to look at, complication. Remember, there's the 3 things: infection, thromboembolism, and the bleeding disorder. So this is the DVTs. We can look for these when we are having, when we're palpating the women's legs. We're going to look for signs of redness, warmth, edema, and not being able to palpate the pedal pulses. If you see that in one side of the leg, you should suspect DVT. And we know that the main worry we have with a DVT is that it can dislodge and cause a pulmonary embolism. And so if we see any of that, they're going to have to get them on the blood thinners and that whole kind of, you guys know how to care for DVTs from your med-surg classes. So how we prevent this in the postpartum unit is we want our patients up and walking as quickly as we can. For those that can, the C-section patients, we put those compression stockings on them, and we want to keep them hydrated and keep their legs elevated, and even pointing their toes, that kind of thing, so that they keep the blood moving through their lower vasculature. If we do see a DVT, we're going to, like I said, give it anticoagulant therapy, rest, and we're going to have her with those anti-embolism stockings. So the next one of the 3 is postpartum infections, and there's quite a different number of infections that can happen. Endometritis is the infection of the uterine lining. Remember, where the placenta was adhered or attached to the uterus. That is an open wound, and it takes several weeks for that to heal. So with a C-section, you have increased risk. That's why we want to give them prophylactic antibiotics whenever we give a C-section. And the signs and symptoms of these infections are kind of similar, but you'd see lower abdomen tenderness, of course, elevated temperature, foul-smelling lochia. She doesn't want to eat. She's nauseated, and she's tired. With any kind of wound infection, I'm talking lacerations, C-section incisions, or episiotomies, we want to look for Rita to see if there is sort of infections and teach our patients to be able to identify if there's infections. So any drainage, unapproximated edges, edema, erythema, tenderness, discomfort, and then of course maternal fever. And then when we do labs, we're going to look for elevated white blood cells. UTI is a common occurrence postpartum, and it's a lot of times caused when we do a C-section when we're catheterizing them, right? We want to get that catheter out as quickly as possible. Most common cause of that postpartum fever that they come in for. So all of these are, you guys know, the signs and symptoms of the UTI. And then the last one, this should say mastitis, which is inflammation of the mammary gland. It's very, very common. The risk factors are infrequent, inconsistent breastfeeding, because this is a clogged milk duct. So if the milk ducts aren't getting, if there's any sort of like milk stasis, then there is a risk for having that infected. And so women really think about stopping breastfeeding because they don't want to give the staph infection to their infant, but most often it comes from the baby and they give it to the mom, or they kind of transfer it back and forth. And so we want women to keep breastfeeding. In fact, if a mom puts the nose of the baby, so positions the nose of the baby to where it's pointing towards where the mastitis is, that's where the really greatest kind of sucking capability comes from the baby. So the baby will be able to release that clogged milk duct. And even if she's on antibiotics, it's totally safe for the baby. And that really clears up that mastitis pretty quickly. If she's not breastfeeding, then she'll have to pump or manually express to get that clogged milk duct moving. These are the signs and symptoms of it. And we treat with emptying the breast, like I said, and controlling the infection with antibiotics. And we'll give them ice or warm packs to help with to help comfort measures. Okay, this is the end of postpartum complications. The last slide I'm going to do, or last PowerPoint presentation I'm going to do, is the postpartum hemorrhage summary. So I will pause here and we will start with the next one.